Welcome to the Deep Dive. If you work in healthcare, you know that few areas of practice carry higher ethical and legal stakes than making decisions for patients under 18.
Definitely.
So today, we're taking a scalpel to the core GMC guidance for doctors on, decision-making, consent, and best interests for children and young people. We are diving deep into the rule book that covers everyone from newborns right up to their 18th birthday.
That's right. And it's not just policy. It's the fundamental framework you have to rely on every single time you interact with a young patient.
Right.
So our mission today really is to distill the core requirements, specifically around best interests, capacity, and confidentiality. And the reason for that is to equip you to navigate these really complex scenarios and make sure your decisions are always ethical and, lawfully sound.
Which is pretty much the definition of professional competence. And this deep dive is just so essential because the challenge, it isn't the science, is it?
Yeah.
It's balancing the child's evolving right to self-determination, their autonomy, against our non-negotiable professional duty of safeguarding. And where those two duties collide, that is where the most high-yield, high-stakes decisions always happen.
Yeah.
So let's just start right in the middle of that tension. Imagine a very, very common scenario. You've got an articulate, seemingly mature 17-year-old patient. They've just been diagnosed with a significant chronic illness, need strict daily medication, frequent reviews.
Okay.
The law presumes they have capacity at this age.
Yeah.
But they tell you, very firmly, they refuse to let you share their diagnosis or their treatment plan with their parents.
Right. And here's the catch.
Here's the catch. The parents are the ones who organize all their logistics appointments, pharmacy pickups, all the practical support they absolutely need to stay well, so you're caught. Confidentiality versus their overall welfare, which clearly relies on their parents' support.
That scenario is the perfect illustration of, why this guidance exists. If we can boil all that complexity down to a single guiding core truth for treating patients under 18, it's this. While your primary professional duty is always to the patient first, successful decision-making demands this delicate balance between the child's evolving capacity, appropriate parental involvement, and the overarching legal and ethical principle, and that is, you must always act in the best interests of the child or young person.
So why does the GMC spend so much time, so many paragraphs detailing all this? I mean, the stakes are obviously incredibly high.
They are.
This isn't just about avoiding a legal challenge. It reflects the GMC's fundamental expectation that doctors must actively safeguard and protect the health and well-being of children.
Exactly. And that health and well-being mandate, it covers everything, not just the immediate physical needs. It includes their emotional welfare, their psychological health, their future development.
Yeah.
And this brings us right to the key challenge, which is a really common exam trap. Just assuming that age automatically grants or denies the ability to make decisions.
Right, the date on their birth certificate.
Precisely. The law for 16 and 17-year-olds differs slightly depending on where you practice in the UK. But universally, the GMC acknowledges that children are often vulnerable, they find it hard to access services, and they need our active help to make these complex choices.
So if the stakes are that high, we really need to break down the three pillars that support every decision we make in this population. Let's start with the foundation, the best interests principle.
Best interests. It's the absolute guiding star. The GMC states that this must guide all decisions, but, identifying it isn't always easy because it's not just a clinical calculation.
It's not just about the medicine.
Not at all. It includes what is clinically indicated, yes, but you have to factor in so much more. We can lock down the key components using a simple memory hook. Think of the 4 Ps of best interests.
Okay, the 4 Ps.
So the first P is patient views, including any preferences they've expressed before. The second is parental views and the views of others close to them. The third is professional views, so other healthcare staff involved in their care. And the fourth is perception. And by that, I mean the cultural, religious, and other personal beliefs and values that are relevant to the child.
That inclusion of beliefs and values is so crucial because the guidance explicitly warns doctors, doesn't it, against making unjustified assumptions.
It does. You must not base your judgment of best interests on irrelevant or discriminatory factors like the child's behavior, their appearance, or disability.
Yeah.
If you see a young patient whose behavior is challenging, you still have to weigh their best interests completely impartially.
Okay, so from that foundation, we move to the pivot point, assessing capacity to consent. This is where we work out who gets to decide.
Yes, and the definition here is really clear. The young person must be able to understand, retain, use, and weigh the nature, purpose, and consequences of the treatment.
And the consequences of not having it.
Exactly, and be able to communicate that decision back to you.
That assessment sounds really fluid, though, not fixed. So how do we account for the fact that a 15-year-old might be able to handle one decision but just not another?
That's a critical distinction. Capacity is entirely decision-specific. To help you visualize this, let's introduce the complexity scale.
Okay.
Imagine a scale from 0 to 10. 0 is consenting to paracetamol. 10 is consenting to complex, life-altering, high-risk surgery. A 14-year-old might have full capacity at level 2, a simple vaccination, but be completely unable to weigh the risks at level 9.
So their capacity is measured against the specific decision's complexity.
Precisely. Legally, we separate them. Young people, so typically 16 and over, are legally presumed to have capacity, but we still test them against that complexity scale.
Right.
Children under 16 are assessed using the Gillick context. Capacity there depends entirely on their maturity and their understanding of what is involved, decision by decision. The young person who holds capacity for that decision holds the decision-making authority.
Which brings us to confidentiality. So if that 17-year-old, in our opening scenario, has capacity, we have the same duty of confidentiality to them as we do to an adult. And violating that trust can have, well, disastrous results.
Absolutely. Breaking trust can deter young people from seeking essential care, especially for sensitive things. However, this is one area where our duty to protect them can outweigh confidentiality. There are 3 key situations where disclosure without consent is permitted.
Okay.
Firstly, when there's an overriding public interest. That means protecting the child or someone else from a risk of death or serious harm.
Right, that's the big one.
That's the big one. Secondly, when the child lacks capacity and sharing the information is explicitly in their best interests, say, sharing some basic information with a parent so they can safely manage the child's condition. And thirdly, when disclosure is legally required, like a court order. If you're faced with a serious risk, prompt disclosure to the correct agency is mandatory.
So when you're faced with a real-time dilemma, you need a safe path forward. Let's map out the 3 high-yield actions. What to do first, next, and last. This is your sort of procedural playbook for these scenarios.
Yeah, and the stepwise process is crucial for scoring well. So step 1, communication and capacity. You talk directly to the child or young person, ideally in a private space.
On their own.
Yes. Assess their understanding and their capacity for that specific decision. Even if they lack capacity, they must be involved as much as possible and make sure they know they can change their mind or get a second opinion.
Okay. Step 2.
Step 2 is involvement and consent. If they are competent, you obtain their consent for the procedure. You must also strongly encourage them to involve their parents. If they lack capacity, then you obtain parental consent. And remember, consent from one parent is usually sufficient if they have parental responsibility.
And then step 3, if things go wrong.
Step 3, conflict and escalation. If you reach an impasse, say, a competent young person refuses life-saving treatment, or parents refuse clearly indicated essential care, you stop.
You just stop.
You stop. You must immediately involve senior colleagues, like the named or designated professional for child protection, and you must seek formal legal advice before you attempt to override either the young person's or the parent's refusal.
That escalation is the moment you really demonstrate you recognize the weight of the decision. That moment, asking for legal advice. That's where you know you've moved out of the purely clinical realm and into the ethical legal fire.
It's a necessary check.
Now let's use that framework to dissect the most common setup patterns you're likely to see. These scenarios repeat because they are the perfect tests of the guidance.
Okay, let's start with pattern 1, the sensitive service request. This involves a young person, usually under 16, seeking sensitive services like contraception, STI tests, or abortion advice without their parents' knowledge.
The classic scenario.
Exactly. And the test here is applying the Gillick criteria and balancing confidentiality with protection. Your best action is to confirm they understand the full implications. You try to persuade them to tell their parents, confirm their health is likely to suffer if treatment is denied, and then you proceed only if it's genuinely in their best interest to maintain that confidentiality.
The trap.
The tempting trap is immediately denying treatment, which puts them at higher risk of harm, or immediately calling the parent, which just destroys all trust.
Right. Okay, pattern 2.
Pattern 2, parental dispute on non-therapeutic procedures. This usually involves procedures driven by cultural or religious beliefs like non-medically necessary male circumcision. Here, what's being tested is best interests in a cultural or religious context. Your best action is to ensure the procedure is permitted by law, factor in the social and psychological benefits they might get from those beliefs, and only proceed with the appropriate consent. You can't just assume that because it's non-therapeutic, it's automatically harmful or wrong.
Right. And the last pattern.
Pattern 3. Child protection concern or abusive sexual activity. This is the immediate crisis scenario.
Yeah.
The test here is the public interest override of confidentiality. Your best action is immediate action and disclosure. If the risk is death or serious harm, you must share information promptly with the appropriate agencies, police, social services, the designated professional.
And document everything.
Always document your discussion and your reasoning for disclosure. Delaying to investigate further or trying to handle it all alone are just dangerous actions that violate your duty to protect.
Knowing the right path is crucial, but knowing the paths that score poorly is equally vital. Let's detail the most common trap answers, the actions that violate those core GMC principles.
The first major trap is delaying or ignoring concerns about risk. If the risk of death or serious harm is present, you cannot delay action to get more information or wait for a senior doctor to arrive next week. Immediate protective disclosure is mandatory.
Okay, what's next?
The second trap is assuming parental rights are absolute. This is a common misunderstanding. A parent cannot legally override the competent consent of a young person to treatment that you believe is in their best interests.
So capacity wins.
Capacity overrides parental objection in this specific context.
And related to that, what about when the young person themselves refuses treatment?
Well, that leads to the third major trap, jumping to overrule a competent refusal. If a young person with capacity refuses life-saving care, you have to remember this is profoundly complex. Before you even think about overriding that refusal, which usually needs a court order in England, Wales, or NI, you must involve the multidisciplinary team and seek legal advice. You never unilaterally decide to treat against a competent patient's wishes.
Got it.
Fourthly, there's the trap of being chaperone dependent. You have to avoid giving the impression that young people can't access services without a parent. The guidance notes that having a chaperone present can actually deter young people from being frank, which undermines communication and trust.
And the last one.
A clear professional trap. Ignoring the BNF for children. If you're prescribing, you must show you're familiar with the specialized British National Formulary for Children. Failing to consult the right resource just demonstrates an awareness gap regarding safe prescribing standards in the pediatric population.
Okay, let's quickly run through some rapid-fire situations to really cement the practical takeaways.
Good idea.
So, a 15-year-old is prescribed medication, and you realize you haven't seen them alone yet.
You ensure you make time to see them on their own at the next opportunity. You have to respect their right to confidentiality and open the door for frank discussions.
Okay. If two separated parents both demand immediate and complete access to their child's records,
You allow both reasonable access, provided they both retain parental responsibility. Divorce or separation doesn't extinguish those rights.
right. And what if a young person with capacity asks you to withhold information about their condition from them because it might cause them upset?
You should only withhold information if you believe it would cause them serious harm, not just general upset, or if they've explicitly asked someone else to make decisions for them. Otherwise, they have the right to know.
That brings us to our final three core takeaways for this deep dive into 0-18 decision-making. Number 1.
The guiding principle for all decisions is the child's best interests. That means factoring in clinical need, their views, their beliefs, and the views of their parents and professionals. The 4 Ps.
Number 2.
Capacity is fluid and it's decision-specific. While 16-year-olds are presumed competent, children under 16 must be assessed based on their individual maturity and ability to understand and weigh the options for that specific choice. That's our complexity scale.
And finally, number 3.
Confidentiality applies to children just as it does to adults, but it must be overridden promptly when it's necessary to protect the child or others from the risk of death or serious harm. You have to remember that the legal guidance around children is, well, it's necessarily complex precisely because it's designed to protect the individual rights of a uniquely vulnerable population while managing the input of parents. And whenever you face doubt or conflict, the instruction is clear. You must seek advice from experienced colleagues or a named or designated professional for child protection.
That mandate to escalate is your ultimate safety net. Thank you for joining us for this deep dive. As you reflect on this guidance, maybe consider again that opening scenario. How do you ethically and lawfully manage a refusal of life-saving treatment by a young person you deem fully competent? It's a powerful question, and the answer lies in knowing and applying these precise GMC standards. We'll catch you next time.